giving this opportunity. And this topic is outset of this asthma and COPD. But it is very important because the infertility is increasing and the patient counter with the physician. So it is very important what are the basic things for the infertility before going to the IVF. Don't advise every patient to go for the IVF. Before that, you can do the basic test. So I invite Dr. Smriti. She is an associate professor in the Department of Obs and Gynae, and she is going to talk on infertility management before IVF.
Thank you, ma'am. A very good afternoon, respected chairperson, the organizers, my senior colleagues and dear friends. I would first like to thank Dr. Suryakant for inviting me over to discuss such a relevant topic, infertility management before IVF. I'm sure all of you would agree, over the last few years and decades, IVF treatment has grown by leaps and bounds. I think we can spot an IVF center in almost many IVF centers in every city. Now, this has created a lot of confusion, not only among the patients, but also among the doctors, as to what to do. Should we continue with the conventional infertility treatment or go ahead with the IVF, the so famously called test tube baby? So over the next couple of minutes, I would first like to discuss about what exactly is infertility, what is the burden of the disease we are facing, what should be the stepwise approach of management of infertility, and what are the true indications for IVF, what to expect of IVF, and what options do we have if IVF fails. Now, infertility has been traditionally defined as inability to conceive within 1 year of regular unprotected intercourse. So 1 year of time frame is very important to remember, but only in cases if a woman is more than 35 years of age or she has oligomenorrhea, that is, she has infrequent periods, she bleeds only every 2 to 3 months, we must begin the investigations early, that is within 6 months itself. The overall incidence is found to be around 10 to 15% in the entire population, and we would be surprised to know that 1 in every 6 couples visits a physician for infertility treatment. That is how big the burden is. When I was preparing this talk, it just came to my mind, are there any anecdotes of infertility treatment in Indian mythology? And I'm sure we all remember that there were some queens of childless kings who were given some kind of magic potions by the sages, which ultimately helped them to conceive. Have you ever wondered what those magic potions were? Were they actually fertility drugs or metaphors of donated semen? We also know in Mahabharata that Vichitravirya died childless, and his mother invited the sage Vyasa, and that is how we had Dhritarashtra, Pandav, and Vidur. Now, is infertility actually a disease? Well, WHO says that a person is defined as healthy if a person is physically, mentally, and socially well. In that scenario, infertility is definitely an unhealthy state because it creates a lot of mental trauma to the couple who has the fear of remaining childless for the entire life. A lot of changes have happened in the society over the last few years, which have also contributed to rise in infertility. For example, early exposure to sex, multiple sexual partners. Women are more career-oriented, and so they keep postponing their pregnancy to more than 30 years. Lifestyle issues like obesity, which we all agree is a huge pandemic. And environmental and toxic agents, especially addictions like smoking and alcohol, they have all contributed to infertility now. In developing nations, the incidence is even higher. 1 in every 4 couples has been found to be affected by infertility. Now, if you look at this geographical map, it shows that India is one of the high prevalent nations where infertility affects quite often. Now, what actually happens? It is found that the highest chance of conceiving is within the first cycle of unprotected intercourse, and the likelihood of conception reduces as the time period advances. So the cumulative pregnancy is 60% within the first 3 cycles, which is reduced from 30% in the first cycle itself. 70% within the total 6 cycles, and 90% of the couples conceive within 1 year. So that is why we have the incidence of around 10% of the couples who do not conceive in 1 year's time. Very often, I'm sure all of you also encounter the situation that a couple who just gets married, maybe 2 or 3 months, comes worried, डॉक्टर बच्चा नहीं हो रहा है, बताइए क्या करें, हमें ट्रीटमेंट शुरू करना है, टेस्ट ट्यूब बेबी करा लें क्या? These are the first few questions which any couple asks. It's our duty to tell them, to reassure them. Tell them about the fertile period, and as I said, only 2 conditions, for example, if the woman is more than 35 years or if she has oligomenorrhea, that is, she does not get regular menstrual cycles. These are the only 2 indications when we must begin our investigations early, otherwise we must wait for a year. But during this 1 year, we must tell the patient about the fertile period, about which I would be explaining. Take this opportunity to start folic acid, because we know that folic acid is very important and should be given to every woman preconceptionally. It helps in preventing neural tube defects. If a woman is obese, we must take this opportunity and advise her to reduce weight. And if there are any medical disorders like thyroid, diabetes, or hypertension, it is this time that we must control it before she plans or before she actually gets pregnant. Now, if you look at the menstrual cycle chart, if a woman has a 28-day menstrual cycle, actually there is a small window, only 4 to 5 days in a menstrual cycle, when she would actually get pregnant. So as doctors, as the first treating physicians who are going to encounter these couples, it becomes important that we explain to them this fertile period window, which is if a woman has a 28-day cycle, we expect that she's having ovulation around the 14th day. So around 3 days prior to that, that is maybe around 10th or 11th day, till 1 day after the ovulation is the time period she is going to be fertile. So that means, mota if you remember, from day 11 to day 15, or if we want to broaden it a little more, because a woman may have menstrual cycle maybe at 28 days, maybe at 30, maybe at 31 days, because 2 or 3 days, it does not matter. So if we broadly remember that day 11 to day 18 is a fertile period of any lady. And we tell her to stay with her husband over these periods. There are good chances she would conceive on her own without any treatment at all. Ultimately, if a couple actually comes to us after a period of a year and we have to start evaluating, we must keep in mind there are certain basic causes. Males solely can contribute to 1/3 of the cases of infertility. Females solely in another 1/3, and both partners together contribute in another 1/3. Among the females, again, 1/3 is contributed by the tubal and peritoneal factors, 1/3 by the ovulatory problems, that means she is not ovulating, another 1/3 by cervical factors or some other unexplained factors which we do not know about. So once the couple comes to us, we must begin with a medical history. We must ask and do a general examination, ask her about her sexual history. If the partner is experiencing any kind of sexual dysfunction in the form of either erectile dysfunctions in males or vaginismus in females. We must also ask regarding the timing of intercourse, if the couple is actually aware of the fertile period. Any long medical illness like tuberculosis, very, very relevant. And if she has lifestyle issues, they also have to be looked into. Now the evaluation, we want to categorize it in 4 major subheadings. One is assessment of menstrual cycle, which can be done by asking a patient to note a menstrual chart, how many days she is bleeding, how often she is bleeding. Or if you want to be more objective, we can do a transvaginal sonography to document ovulation. I would discuss that in detail later on. Or nowadays we have the iSure strips available, which picks up the urinary LH, which tells you that a woman is going to ovulate 24 to 36 hours after. The double line is present on that, which tells us about the urinary LH. Or we have to, the next subheading is assessment of anatomic function. For example, we want to look if tubes are normal or not, if the uterus is normal or not, which can be done primary measure by hysterosalpingogram and laparoscopy as well. We will again come to those details later. Ovarian reserve is another very important to know what are the chances of the woman conceiving. That also can be measured by biochemical as well as sonological parameters. And as I said, male partner contributes solely to 1/3 of the infertility causes. Husband semen analysis is paramount. Now, whenever we ask the patient to do a tubal patency test, which is very, very important, we must ensure that this test is done between day 7 to day 10 of menstrual cycle. Why is it so? Because we want to do this test in the post-menstrual and pre-ovulatory phase. She is going to ovulate around the 14th day, and if we conduct this test later on, we might just disturb a pregnancy. So we must always do this test in the pre-ovulatory phase, that is around day 7 to day 10 to day 11, which is a safe time when we can conduct this test. The first step to conduct a tubal patency test should be by hysterosalpingogram, which is done by using a radio-opaque dye, which is urographin 76%. However, if the hysterosalpingogram shows any kind of abnormality, or if there is cornual spasm or the tubes appear to be blocked, we must always confirm it with the help of diagnostic laparoscopy, because laparoscopy also tells us about the presence of any other peritoneal factors which may contribute to infertility. For example, adhesions, for example, endometriosis. Now, sonography for ovulation is another very objective way to look for ovulation. We must do a baseline scan, and then whenever we want to do the test, it should be done from day 8 onwards, maybe every 2 to 3 days. So the follicle appears nice round, and there is usually a dominant follicle after we have given the ovulation induction drugs. Then we must follow up the patient, do serial scans, and then the ruptured follicle appears irregular with crenated margins, and there is also some amount of free fluid in pouch of Douglas. It's a very, very simple way to assess sonologically if a woman has ovulated or not. Now, the tests for ovarian reserve are many, but I would only want to highlight that baseline FSH, baseline means which is done between day 2, day 3 or day 4, that is all. So if FSH is to be done, it has to be done in the baseline period, and if that test says that the report is more than 15 milli international units per ml, that indicates that the woman has a poor ovarian reserve. Another important test is serum AMH. Here, the AMH is produced by the preantral follicles. So the lesser the number of preantral follicles, there would be smaller amount of AMH being produced. So if the value is less than 0.7 nanogram per ml, that indicates a woman has a poor ovarian reserve. And antral follicle count, that is, antral follicles are the follicles which are between 2 to 10 millimeter in size at baseline, that is day 2, day 3 or day 4. So if the antral follicle count is again less than 3, that indicates there are very few antral follicles left, and this woman is not going to respond well. Now, semen analysis, WHO has given, this is the latest criteria, 2010. Now, we must remember whenever we suggest for a semen analysis, we must tell the male partner that the sample should be collected after 3 to 5 days of abstinence, collected by masturbation technique, and should be transported to the laboratory within 30 minutes of collection. Now, the important points to remember here are that the volume is around 1.5 cc. The sperm concentration should be 15 million per ml. Any number less than that indicates that the male partner has oligospermia and needs treatment, and at least needs a urologist to look at the patient, or the physician himself can do it. The percentage motility should be at least 40% with forward progression in 32%. Anything less than that means the male partner has asthenozoospermia, again needs a lookup, and normal morphology should be at least 4%. And again here, if it is less than that, it means it is teratozoospermia. Now, once we have evaluated, so there are 4 important tests which we do: tubal patency, ovarian reserve, test for ovulation, and semen analysis. Once we have done these 4 tests and we realize that everything looks okay, then we can begin the management. In the management, age of the women and the duration of infertility are the most important determinants which tells us what are going to be the chances of success. But as we can see in today's scenario, increasing patient pressure, नहीं डॉक्टर साहब 4 महीने हो गए हैं, आप हमारा कुछ इलाज करिए, हमारा बच्चा नहीं हो रहा है. And the financial interests also of some infertility centers have unfortunately trended to start infertility treatment a little too prematurely. Now, there are 4 important strategies whenever we want to treat an infertile couple. One is expectant, which I said can be easily given for a period of 1 year, allowing the patient to conceive on their own. Next is ovarian stimulation. Third is ovarian stimulation along with intrauterine insemination, a form of artificial reproductive technique. And the fourth is in vitro fertilization, the so-called test tube baby. But we must remember that infertility treatment is simple, it has a lower cost, and it is quite effective. As compared to an IVF treatment, which is definitely more complex, risky, involves a lot of hormonal injections, and a lot more expensive. So we must always stick to infertility treatment conventional first. Only if that fails, we must go ahead with IVF. Now, ovarian stimulation, here we use certain fertility drugs. I would not go in much detail, but these fertility drugs are the 2 commonest fertility drugs are clomiphene citrate, which is given in a dose of 100 to 150 milligram. Either we can start on day 2 or day 3 or day 4 or day 5. This is given for a period of 5 days, and then we do a sonography to look if the ovulation is happening or not. The next method to induce stimulation is by exogenous gonadotropins, which are started in a dose of 50 to 75 international units per day, and as per how the follicles are growing can be titrated accordingly. Intrauterine insemination, it means placing of sperm which has been processed and washed in the laboratory in the uterine cavity just at the time of ovulation or prior to ovulation. It is no hi-fi technique, it's a very, very simple technique. The idea is that you want as many sperms as possible to be present around the ovum once it is released. The classical indications are if the male has an ejaculatory problem, if the female has vaginismus, or if there are cervical factors which are not allowing sperm to penetrate and reach the ovum. This is a very simple technique. It does not require any IV sedation, does not require any anesthesia. It can be done in your chamber itself. After the patient lies down in the lithotomy position, the speculum is inserted and the IUI cannula along with the tuberculin syringe, around 0.7 to 0.8 ml of the media along with the semen is placed inside the uterine cavity, and the woman is asked to lie down for at least 10 to 15 minutes after the procedure is done, and that is all. But we are not successful in all the cases. We are not able to help the couples only with ovarian stimulation and IUI. And that is when we must go to the next step, which is IVF. Now, in certain cases, we can actually straight away go to IVF, which is bilateral tubal blockade, which we have confirmed by laparoscopy. We know that this is not a false positive. If there is moderate to severe endometriosis, believe me, ovulation induction with IUI is not going to help. We are only going to waste time, and we must proceed to IVF straight away. If the male partner has severe oligospermia, the sperm concentration is less than 5 million per ml. Even the IUI process is not going to help much, and it would be better if we proceed with IVF. Or if we have given the traditional treatment and 3 to 6 cycles of clomiphene citrate with IUI or gonadotropins with IUI have been given and patient does not conceive, this is the time to go for IVF. Now, IVF procedure, which is called as a test tube baby, there are very basic steps of it. First and foremost is to select the patient. Then we must suppress the ovaries, make them quiet so that they're not producing hormones on its own. And then we give heavy hormonal injections to stimulate them. After the eggs are formed, we retrieve these eggs. Then we inseminate these eggs, and after these eggs are inseminated, they are put back inside the uterus. So first we quieten the ovaries, then we give heavy doses, and then under ultrasound guidance, and here we require good anesthesia because this is going to be a painful procedure as we are inserting a needle through the vagina into the ovaries and aspirating the ovums which are formed. After the ovum is retrieved, the oocyte is retrieved, it is kept in the petri dish in, of course, the incubators which are provided and inseminated with the husband semen. Or if the sperm counts are too low, then we have to go ahead with ICSI. ICSI is intracytoplasmic sperm injection. Here one motile sperm is picked up and actually injected inside the ovum in order to make it fertilize. After the resultant embryos are formed, They are transferred into the uterine cavity, just like how IUI was done. But we must remember that IVF success depends upon how the ovum are. What quality is it? Number of sperms which are there in the male partner. What indication have we done? For what? For example, in cases like endometriosis, the success rate is still poor. For example, if it is a case of genital tuberculosis, the success rate is still poor. What is the quality of embryos which are formed and how the embryo transfer has been done? Even in the best of centers, believe me, my friends, the success rate of IVF is only 20 to 40%. So these things must be explained to the patient because they have very, very high hopes when they come to the clinic, and they obviously get extremely disappointed. So we must tell them all these things beforehand, what is going to be done and what should they expect out of it. Now just briefly, suppose if you have a case of ovulatory infertility, that is a woman is not ovulating. What should be and the most common cause is PCOS. So what should we do? We must remember that clomiphene citrate is the best drug to induce ovulation. So we must try with that. If the woman is not ovulating with clomiphene citrate, it is good to add metformin in these cases because metformin helps in combating the insulin resistance. In a dose of 1500 milligram per day, it has been shown to improve ovulation results and pregnancy rates drastically. If this also does not work out, before we go to IVF, we must always take the patient for laparoscopic ovarian drilling and then give her ovarian stimulation. If it is the cause is male factor, then as I said, ejaculatory problems, or if it is oligospermia or presence of anti-sperm antibodies, we can go ahead with IUI. But if the count is too low, or if a patient has obstructive azoospermia, or there are no motile sperms at all, then there is no point in doing an IUI. We must go ahead with IVF. The patients who have unexplained infertility, that means there is no cause which we can identify. The tubes are patent, the male semen analysis is all right, she's ovulating, but she is not conceiving. So these are the patients which come under unexplained infertility, quite difficult to treat. Expectant management, no role. We can give clomiphene citrate along with IUI 3 to 6 cycles depending upon the age and the ovarian reserve of the lady. If this does not work, then IVF is the option. If a woman has a tubal factor, if one tube is blocked, even then ovulation induction and IUI can be done. But if both the tubes are blocked, then there is no chance, then we have to go with IVF. We must also remember that if a woman has hydrosalpinx along with the tubal blockage, this hydrosalpinx has to be dealt before we can proceed to IVF because this hydrosalpinx has a large amount of fluid and this fluid will not allow embryo implantation to happen. So if there is a hydrosalpinx, it has to be clipped at the proximal end or the tube has to be removed. IVF will not work again, as I said, in all the cases also. The women who have poor ovarian reserve, ages more than 40 years, or the endometrium is very poor because of tuberculosis, Asherman's, or pelvic inflammatory disease, these are the women who are not going to have a successful IVF. And if 3 cycles are attempted, even in other cases, and she does not conceive, these are the conditions where we have to look for alternative options. But now, what are the alternative options? There aren't many. It's either adoption or third-party reproduction, which has come in big way, where we have sperm banks, we have ovum banks, we have embryo banks, or we have surrogacy. So these are the options which we can explain to our patient. So to summarize, infertility should be evaluated in both the partners simultaneously. We must do a stepwise diagnostic evaluation. Management ultimately is going to depend upon what is the cause of infertility. And in those cases which permit ovarian stimulation with IUI should be the first option. 3 to 6 cycles, patient does not conceive, then we can go ahead with IVF. But after IVF, we know what are the subsequent options available. So you have not failed until you quit trying. So we must not give up. And I'm sure that with our attempt, most of the patients would be happy at the end. This is a beautiful picture by Annie Geet, where we can see a baby coming out of an egg, which exactly is what we want. Thanks a lot for patient hearing.
Thank you. Now the few tips for the infertility. You are the physician, the first patient comes to you. Always take the history with the couple, female and male. ask the patient if she is staying with the husband or not. Sometimes क्या होता है, डॉक्टर साहब मेरा इलाज कर दीजिए, हस्बैंड कहाँ है, वो आर्मी में है, 3 महीने बाद आएंगे. तो first, they are staying with regularly or not. Second, take the history of any chronic illness, simple vaginitis, infection of the lower tract, simple pelvic inflammatory disease can cause the infertility. So examine the patient for any vaginal infection, examine the husband for any infection, and examine for the pelvic inflammatory disease. For that, the government has started the syndromic approach. So if the patient is coming with a discharge, lower backache and lower pain in abdomen, simple doxycycline treatment can help the patient if it is because of the pelvic inflammatory disease. So before coming to the IVF, you should know what are the basic things that should be ruled out. And before induction of the ovulation, one thing remember, giving the hormone to the woman for the ovulation, see the tubal patency test. Is the tube is patent, then it will work, otherwise it will not work. Thank you very much.